So Tom, we're at ASCO 2025. One of the pieces of data being presented is the 9-year follow-up from CheckMate 214, a final analysis. And we've had final analysis presented of the other 3 main IO-TKI regimens. Axi-Pembro, Cabo-Nivo, and Len-Pembro have all presented their final analysis, although at different lengths of follow-up for what it's worth. But the numbers are in, there's not gonna be more analyses, et cetera, et cetera. So I think there's some take-home lessons. Let me tell you what I think the take-home lessons are. You can comment. So clearly, immune-based doublets are better than single-agent TKI across the board. And we can dive into the IMDC risk groups if you want, but let's just focus on ITT first, because I know you're going to talk about favorable risk and annoy me. But anyway, so in an ITT population, an immune-based doublet has less early PD, higher response rates, longer PFS, and better survival. That'd be, for me, take-home number 1. If you look at, and we should say that obviously we're kind of comparing across trials here, and there's different eligibility, different patient proportions, different lengths of follow-up, so all the imperfections of comparing across trials, but be that as it may.
You're going to do it anyway?
We're going to do it anyway, yes. We always say we're not going to do it, and we do it like 3 seconds later. So for the OS hazard ratios, the IO-TKI regimen started very low and then have sort of crept up over time.
0.53.
0.53
I gave you a t-shirt.
From Axi-Pembro, yes.
0.5
for the t-shirt.
They drifted.
And they've drifted up over time. Whereas the data that we saw at ASCO for the Ipi-Nivo hazard ratio has been almost identical, basically 0.7 plus or minus a couple hundredths here or there, almost identical. And I think one of the strengths of Ipi-Nivo, both as a regimen and a data set, is consistency and durability of response, right? Those people who respond over 50%, I think it was 56% at the last analysis, maintain that response. Although I will say, if you look at the PFS curve, we both know there's a lot of censoring that happens on those curves, especially as you get to the tail.
About that.
I know you get upset, but the number, it doesn't level off. It still goes down a few percentage, even as you get to year 5 and 6 and 7 and 8 and now 9. So, and it's important because if I'm a patient,
we're curing some patients.
We're curing some patients, that's important. But you can also have, I guess, I don't know if you call them late relapses, late progressors, you know, and I've seen that in clinic, right, where people have been on for 5 years, et cetera. And, you know, so the curve isn't completely flat. That was an observation for me.
But you lose some patients early on with Ipi-Nivo. You don't get control of everyone.
Correct.
Progression of disease occurs.
Yes.
And not everyone sequences therapy. So it swings and roundabouts.
It swings and roundabouts, yes.
Yeah. And the second point is the VEGF-TKI IO combinations. When you look at the landmark analysis at 5 years, at 4 years, at 8 years, and Ipi-Nivo, while the shape of the curves might be slightly different, the landmark and the control arms are about the same.
The landmark in the control arm.
Sorry, the landmark in the study arm. I apologize.
In the study arm.
So the landmark, Axi-Pembro, landmark analysis at 5 years, and Ipi-Nivo landmark analysis at 5 years, the survival is about the same. And so when we look into the detail of the shapes of the curve, this one's up and down, this one's down a bit, actually what patients are really interested, what my chance of being alive at 5 years, all regimes are about the same, and cross-trial comparison, as you said before, is really complicated.
Yeah.
But I do want to ask you one question.
Please.
Ipi-Nivo, we kept going with Nivo. As you know, there's lots of discussion about the Ipi bit. So the 914, the adjuvant trial was negative. If it was amazing, Pembro was positive, you'd have expected Ipi-Nivo to be positive and even better. You would have
in the adjuvant setting.
In the adjuvant, you would have expected that. And the biology in adjuvant metastatic disease is similar in many respects. Okay, so that's number 1. So number 2, there's also the 8x8 trial. We haven't heard from that yet. That's Nivo versus Ipi-Nivo. If that was spectacularly positive, we probably would have heard something by now. I think that's fair to say. So the role of Ipi, I know hand Tamara, if you're watching, I know you're upset, I apologise. But the role of Ipi is not a slam dunk in that respect. And you continue going with the Nivo is actually the issue here. And in the other trials, you stop the Nivo or stop the immunotherapy at 2 years.
Generally,
is this tail that you talked about?
Is it just related to Nivo and not the Ipi?
Is it the long term? Those patients who are progression free, I've got some in my clinic and who took part in the trial who continue on Nivo 5 years down the line.
Yeah.
Is it that, or is it the Ipi, Brian?
I have to tell you, though, when I see patients who got Ipi-Nivo and are now 2, 3, 4 years later, I'm getting there, I'm kind of like, I'm not sure you need the Nivo. I totally take your point.
I agree with you. I stop at 2 years.
I tend to stop at 2 years.
I do stop at 2 years.
I also, in my IO-TKI regimens, have a conversation about stopping the TKI. I have plenty of those, not plenty, a large handful of those patients in my clinic who have stopped both at 2 years or about 2 years.
Let's move to TKI stopping them. I'm happy on TKI stopping. So Ipi, we're not sure about. When do we stop TKI therapy? I've got patients who've been on for literally years.
Yeah.
And I don't know.
I don't know the answer. I think it's a tolerance issue.
Yeah.
So if people are tolerating fine, it's like, okay, but often often they don't realize that they're not tolerating fine, right?
Yeah, and you still give them a holiday.
And they're like,
oh, wow.
Yeah, the clouds part and everybody's happy. So
and VEGF-TKI never cured anyone.
By itself, I agree. I tend to be a big interrupter of therapy and give breaks, as you know, and I'm perfectly happy to stop it.
You had a nice study with that one.
Yeah, as long as the patients understand, we're off into uncharted waters here. Anyway, back to the big picture again before we wrap up. The other point I would make...
before we stop, number one, I don't think you should stop in the first year of VEGF-TKI therapy. Would you agree with that?
I don't think you should stop anything unless it's for toxicity in the first year.
Fine. And 2 years, I'm still pretty nervous. After that, I'm between 1 and 2. Okay, before we wrap up, I do want to talk about the favourable risk population, if I may.
Sure.
Because it is
I can hardly wait.
It is debatable. The letter of the law is, although VEGF-TKI-IO combination has higher response rate and better PFS, the hazard ratios long-term for OS are at 1, some of them are even above 1 at this point.
Yeah.
And people like Dave McDernough's not happy with that. He's unhappy with that with patients. And then the IPI-NIVO data, as time has gone by, the curves, the OS curves, and that sort of thing Bob's showing today.
Yeah.
Or is it today or is it?
Today. I think it's today.
They're crossing, the curves are crossing.
Yeah.
And in the end, it has ratio 0.8. And I look at that and think early immune therapy probably is important for some patients. And
I think early immune therapy is important for every patient, and I think there's a subset when we pigeonhole patients into favorable and intermediate and poor. There's a heterogeneous biology, and that's why it's confusing.
Now I'm going to upset Danny Heng now as well. This is the third person, Danny. I apologise, but I don't love the IMDC classification to pick patients for therapy.
Nor does he.
Well, I know that. I agree with that. I think I said other things in the past that upset him. I was apologising for the other things, not that particular. I apologise again, Danny, about that.
So I guess to summarize, I don't know that at the end of the day, people have kind of got into their camps early. Yes. You're an IPI-NIVO giver, you're a Cabo-NIVO, you're whatever. And I don't know that any of the subsequent data has changed people's minds.
I moved a little bit.
You moved a little bit.
Yeah, okay. I have. I've sat before when the Axi-Pembro data came out. I sat on stage with you and we said Axi-Pembro for everyone. We did that at the IKCS. I put a sign up actually, which was which had a spelling mistake. Yeah, a spelling mistake, which was unfortunate. And I have moved my position. So I don't mind, pick one, use it well. I worry about early progression with IPI-NIVO, but I also worry about chronic toxicity with VEGF-TKI-IO. I'm somewhat concerned that IPI may have a role. I'm not clear in my mind about what it is. I'm not as clear as some of the other people. I do not like using the IMDC classification to pick patients for therapy, but I would love to see a biomarker, and I know you're doing a little bit of biomarker work, Brian.
We're doing some biomarker work. You're doing some with PD-L1, and so I think that's what we'd all like. Whether we'll get there soon, I don't know, but I think we're making progress.
And Monty's showing some data in the biomarker session today, looking at dynamic changes on RA signatures, and there's a lot of instability associated with, Samra's work shows that as well. The evolution of renal cancer means what you're treating today might not be the same cancer as you're treating in 2 or 3 years' time, making it not just heterogeneous at baseline and in terms of metastatic sites, but also with time. So it's a sort of 3-dimensional game of chess for biomarkers. Maybe that's why.
All right, let's wrap this up.
I apologize.
9-year data for IPI. I mean, it's amazing that the data was presented 9 years ago, right? I mean, that's what's amazing to me. I have a 25-year ribbon to prove that I was there at that ASCO.
You've also got this volunteer thing out of Fenno.
Anyway, good stuff.
Thanks, Brian.